want to just first say, yes, I have been working as a social work nephrologist for 25 years, and I look this great not because of AI. It is because I actually love what I do, and I am so determined not to let it take me out. I continue to have passion and compassion for our patient population, and I continue to look at how we can continue to be innovative and improve what we do every day. Now, you saw that my last name is Speed, so my goal is to catch us up as close as possible, so hang on. So therefore, I'm skipping objectives, and we're just going to jump right in. My objective is to get done. So the first thing is root cause analysis is something that social workers are always doing, but we don't necessarily get credit for the work, right? Because we just document it and it's never really captured. We just come with the results, we get it done. But what I have found over the last couple of years is that as we continue to capture that data, and we've learned some amazing things just recently from a root cause analysis that we did with patients related to treatment adherence. For years, for the last 25 years, I've always heard that patients are not adhering to treatment because of transportation. And so then they look to us and say, fix it, right? But what we found is that the number one reason that our patients shared for not actually coming to their treatment or completing their treatment was not because of transportation. It was because they said, I feel sick. From that, we've been able to really and support our direct patient care team and what we need to do differently to be able to improve in that way. Also, what we've done, we started about, probably less than about 5 years ago, we started working on an acuity dashboard. And the analytics team have been very vital and crucial in that work. What that has done is because we recognize that our caseloads are fairly high, and so we really needed to be able to look at the acuity and allow it to drive our interactions with which patients do we need to spend more time with. Because we recognize that all of our patients are not created equal. And so we recognize that some patients need a little bit more of our time. They need to see us more frequently. And so we utilize data, not just from what we input into the EMR, but we also use what our dietitians, what our nurses, what our physicians, we take everything that we can and we continue to drive our interactions. And what we have found is that social workers are more satisfied with the work that they're doing, and we're able to decrease hospitalization. We're able to truly improve quality outcomes because we are focusing on the right patients at the right time. So with that, what is it that we can do now in what we're doing? I truly believe that one thing is related to increasing the data touch points. We have the data touch points internally, but we still need to look at all the data points that are external. Like I heard from several others about looking at certain zip codes, looking at some of the social determinants of health, some of these things that we need to look at to be able to plug that in so that our social workers know exactly what's going on with our patients externally as well. Because we're listening, but there's some information that is available to us at our fingertips, but we don't necessarily have the opportunity to touch it. And then improving our workflow. We can improve our workflow, whether with documentation, but I believe there's an opportunity to improve our workflow by simply providing us things like integrating resource navigation. Because resources are often there, but we're having to spend so much time trying to complete all of the applications. But imagine if the information was able to be pulled into those applications. That would save time for our social workers, because I don't know if you knew this or not, but we actually do more than case management. We do more than transportation, and we didn't even learn anything about insurance. No, we didn't. There wasn't even a course on that. We actually are interested in taking care of the case management piece, but we really want to have intentional communication and intentional theoretical frameworks that would really help us to address many of the behavioral patterns that we see with our patients each and every day. And if we had more time to do that and not having to put so much energy into the case management piece, then we could spend more time with our patients so that we could have more guidance on what theoretical frameworks can help them, and to promote patient engagement. When you want to promote patient engagement, it's about empowerment, not enablement. So if we can empower our patients to be able to look for their own resources, they are actually more resilient than we recognize, but we need to make those things more available to them as well. So what are some of the social work perspectives that I identified? So when I looked at some of the research that existed, what I found is one of the concerns that social workers do have, like nurses that have spoken and dietitians as well, is that we still want to have meaningful interactions. At the end of the day, no matter how wonderful AI will be, and how it is right now, is that it cannot replace the gut. Now, I'm not talking about my digestive system. I am literally talking about the feelings that can only happen with human connection. And that cannot be lost, because there are some things that AI won't pick up. They won't pick up the behavior and the posture of the patient, how they're interacting with me, how did their patterns change, only if I documented it. Right? But there's some things that are caught with just a feeling. I know now that even if I do a depression screener, the patient is going to answer it how they've been answering it every other place, every other health space, but I will be able to identify those symptoms by simply looking at them and having a conversation. So that's why we can't just replace it. We have to treat AI as a skeleton, and what I've seen in the room all day is that we're just learning how to put that skeleton together much quicker so that we can spend more time on the meat. And to me, the meat of it is really being able to have those additional conversations. Like if I know already what type of support system you have, I'm going to spend more time on the relationships, because we can't just assume that just because they're married that they're happy. We can't just assume that just because they have children that they like them. So we recognize that we need to have the skeleton, and have the skeleton quickly. And if we had that information quickly, then we could begin to have better conversations with them that's truly going to drive the quality outcomes. Because if you think about it, most of the discussions that we have in QAI is based on what they do at home and not in the clinic. And so we need to understand more about what's happening in their world and less about just what's happening in our world. We need to still demonstrate empathy and care, consider patient uniqueness. Right? There's some things that are just unique to them, and we want to make sure that does not get lost. One of the things that I'm going to skip in addressing ethical and societal implications, we have to consider who's creating and developing these AI platforms. Because if they're a homogeneous group of people, then it's going to miss the diversity of thought that is needed. And so the results of that, the outcomes that we get from that, are going to miss that as well. And so we're going to end up with different biases. For example, in one particular case, they were looking at healthcare and access to healthcare. What they did is that they looked at healthcare spending. You're not going to see the populations that really struggle with access to healthcare if you're looking at healthcare spending, because most vulnerable populations don't have access to healthcare, and there's less spending based on what they're using. What type of insurance they're using. If they're using more Medicaid, there's less healthcare spending. So what actually happened is that the population that truly was most vulnerable was left out of that study based on that. It was left out of that AI platform. And so there are things that we still need to make sure that we can maintain a diversity of thought. So that's why I want to say first, thank you for the love of actually just inviting a social worker and a few social workers into the space, because I believe the diversity of thought begins with understanding that you have to look at the whole person. There's a whole person on the other side of those numbers. And so even with AI, we don't want to lose the fact that there's a whole person. So this is my last slide. I told you I was good. I think it's important that we use AI to support human decision-making. And I'm not talking about the people in this room. I'm not talking about the interdisciplinary team. I'm talking about our patients. How can we help them make better decisions about their care based on what we're able to capture from AI? to help us have the right conversations with them. We want to optimize resource allocation through predictive analytics, and we want to be able to have pattern recognition. Like, one of the things that I've learned this year just from our analytics team is that really, if you look at if they always miss holidays, then we need to figure out why are they always skipping during the holidays. Let's have the conversation. But if I didn't even notice that they were missing every holiday for the last 3 years because we have so much turnover and nobody told me, then we're going to miss that pattern. But if we take those predictive patterns, then we can have the right conversations with the right patients so that we can truly impact them in a way that we can reduce hospitalizations and mortality. And I also propose that we integrate social work-specific AI literacy framework into our core competencies to equip social workers to address challenges while upholding our professional values. I don't want us to lose critical thinking. It may already be lost, but we need to get it back. I don't want us to lose it, but we need to get it back. We want to make sure that we maintain critical thinking, and not just critical thinking of our staff, but we want to maintain critical thinking of our patients as well. And so I don't want that to get lost because we have an easy button to push. The hard and the most important parts are the soft skills, and the soft skills can also be difficult, and people want to skip those, so we don't want AI to replace what the soft skills are. Let's not be afraid of those, because those are the ones that's going to lead us to lasting impact. Thank you.